Hi, I am Dr. Gloria Bowles-Johnson, Assistant Professor in the Department of OBGYN at Georgetown University Hospital. I am going to present a video of a simulation model of a retroperitoneal dissection with the primary purpose to open up the posterior sheath of what would be considered the broad ligament, develop the paravesical space, identify the ureter before safely clamping the ovarian vessels in the infundibulopelvic ligament. The pelvic sidewall is an important space when it comes to pelvic surgery, most importantly when needing to identify the ureter and when unable to visualize it. Understanding and being able to perform a retroperitoneal dissection is very important for the pelvic surgeon. This can be encountered in many different scenarios, such as the distorted anatomy of an enlarged fibroid uterus, in the patient that has had multiple surgical procedures where the pelvis is scarred, particularly in also cases such as endometriosis, ovarian remnant syndrome, and additionally enlarged pelvic masses. This is part of a research project where I am the primary investigator working along with Dr. Willard Barnes and Dr. Irina Tunaj. The purpose of this research project is twofold with two objectives. Number one, the first objective is residents will be able to perform a simulation on a model performing a retroperitoneal dissection. This project is geared towards our senior residents' third and fourth year. The second objective will be that simulation hopefully will improve the operative performance of the resident in the operating room. The project will be as follows. Third and fourth year residents will be pre-assessed with a 9-point checklist and OSAT scoring performing the simulation model of a retroperitoneal dissection. Our fourth years will be the controls. They are our traditional learners who have been learning in the last 3 years of performing in the operating room. Third years will be performing the simulation and will be scored as well. Third years then will have the opportunity to look at this educational video. Fourth years will also have the opportunity to look at this educational video. However, the third years will then be rescored performing the retroperitoneal dissection after looking at this video. The third years then will come back at a separate sitting and will be rescored performing the retroperitoneal dissection. It is our hope with simulation that we should expect to see scores improve. At the end of the year, third years will then be reassessed one more time performing this retroperitoneal dissection. Their scores will be compared to our fourth years that are our control. As stated, it is our hope that retroperitoneal dissection on a simulation model will improve operative performance in the operating room, and hopefully this may become a part of the curriculum of the simulation for our residents at Georgetown University Washington Hospital Center residency program. I will now take you through the simulation. So this is our simulation lab at Georgetown University Hospital. And next you'll see the instruments that are being used for the simulation. And note on our model there is no adnexa, but we will pretend for the sake of the simulation that an adnexa exists. So this is our simulation model of our retroperitoneal dissection. In general, just to point out the structures, here's our uterus. Our Foley catheter is used as our round ligament inserted into the inguinal canal. The uterine vessel is here, and the tissue above is our peritoneal reflection. This is our anterior leaf of the broad ligament and our posterior leaf of the broad ligament. In this model, again, we are simplistically focusing on the first layer of the retroperitoneal space. To reiterate, the spaces of the retroperitoneal are very important. The first layer, as we stated, is the ureteral layer on the parietal peritoneum. The second layer, which is going to be deep actually into the space, consists of our internal iliac, otherwise known as the hypogastric artery, and is there where the visceral vessels of the uterine artery, the inferior and superior vesicle vessels actually are. The lymph nodes are there as well, and this is an important area for GYN oncologists to do lymph node dissections. And the third layer, and again, would be deep into our model, includes our external iliac vessels, which are found on the medial aspect of the psoas muscle, and additionally, the obturator nerve, artery, and vein are found on the anterior portion of the obturator internus muscle. For the sake and simplicity of this dissection, we're going to focus on the first layer. So I am going to take you through the dissection itself. Residents will be scored with a checklist. This is the checklist that residents will be scored. The primary objectives is to identify the posterior peritoneal of the retroperitoneal dissection, enter this retroperitoneal space, develop the paravesical space, identify the round ligament and the infundibulopelvic ligament, and be able to identify the course of the ureter in the retroperitoneal space. This is a 9-point checklist where residents will be scored in doing these particular functions. They will also be scored on a global rating operative scale. The global rating scale of operative performance is a validated tool that has been used in the operating room setting. Residents will be videotaped during the simulation and will be scored as stated with the checklist, but additionally with the global rating scale. The global rating scale will include the respect of the tissue, time and motion, instrument handling, knowledge of the instruments being used for the dissection, flow of the operation, and knowledge of specific procedures. The use of assistance will be deferred at this time, as residents will have assistance part of the simulation training without asking. Now I am going to demonstrate doing the simulation model of a retroperitoneal dissection. Hemostat. Note that it is important when you grasp the round ligament that you would ideally like to grasp it as distally as possible. This will allow you to enter into the lateral aspect of the retroperitoneal space in order for you to do your dissection and finding the ureter and the infundibulopelvic ligament, which will be typically placed on the medial aspect of the posterior sheath of the broad ligament. This is important dissection to be performed in complex laparotomies, including distorted anatomy such as with large fibroid uteruses, also in the sense of actually scarred pelvises related to prior surgery, endometriosis scarring, where it is very difficult to identify the ureter. Additionally, in ovarian remnant syndrome, when we're dissecting out the ovarian remnant, and also for large pelvic masses, this is a very important tool to note how to do a retroperitoneal dissection. So first, may I have a pick up with teeth, please? So first I'm going to grasp my round ligament and I'm going to clamp my round as distal as possible. And I'm going to clamp the other side of my round ligament. Nail scissors, please. Now I'm going to cut my round ligament. 0 5/4 suture ligature, please. Very important when we suture ligate the round ligament, it's important that we do a transfixing suture ligature because the artery of Sampson runs through the round ligament. So I'm going to transfix my round ligament. I'm going to come underneath my round. And then I'm going to come through my round. And for the sake of the model, I'm going to come behind the clamp, although we would be in front of the clamp because I'm pretty distal on the round ligament. Hemostat, please. Tie down with the surgeon's knot, finger to the knot. Go ahead and take my clamp off. Hemostat, please. I'll take another 0 5/4 suture ligature. Some people particularly when doing a hysterectomy, may decide to just keep the clamp in place, but remember the artery of Sampson runs through the round ligament, so whether you clamp it or suture ligate it, you've got to do something. So I'm going to come underneath my round. I'm going to transfix this side so that I can get rid of this clamp. I don't really want to lock it. Thank you. Same thing, I'm going to nice surgical knot. Come off, thank you. And I'll take a hemostat. Suture sticking a little bit to my gloves. Next step, I'm going to take a pickup and Medstar scissors. I'm going to tent up on the posterior peritoneum. And I'm going to open this up. Now in the operating room, your assistant may give you a undermine with a tonsil, which makes it easier, but we're going to open this up. So we're kind of lateral to the side wall. Open it up. And the goal here is to be able to find my ureter as well as the infundibulopelvic ligament. So this is the lateral surface actually of the posterior sheath of the broad ligament. This is typically a reeler tissue that you'll find when you open up this space. This is the triangle that's always talked about, the lateral surface of the pelvic wall, the medial surface of the posterior sheath of the broad ligament. And so I am going to take my fingers. However, you can also do this with a suction. You could do it with the back handle of a hemostat with scissors. We're just trying to break up the areolar tissue that you're going to find here. And deep in the pelvis is your iliac vessels. So if you actually do the motion of laterally spreading, but parallel to what would be your hypogastric, your external iliac vessels, then you won't get into trouble. This is usually an avascular space. So as I spread to separate, I'm now on the medial aspect of the sheath of the posterior, posterior broad ligament. So I'm feeling here now, and my ureter is going to be a Foley catheter. Which should be distal to my infundibulopelvic ligament. In the human body, we can take our finger and we can kind of pull down in this area to feel the snapping of the ureter, which feels like an accordion. However, for the sake of this dissection, we're going to identify it. So here is my infundibulopelvic ligament, my ovarian vein and artery, and deep into the tissue here, is my ureter. So here's my ureter, which is running distal on the medial aspect of the posterior sheath of the broad ligament. This is important because this is what we want to see to make sure we don't injure the ureter, as the ureter is going to course further down, eventually close to the uterine artery, which that distance from the uterine artery further down is going to be about 1.5 to 2 centimeters away. 0.5, I'm sorry, to 2.5 centimeters away, depending on the individual's anatomy, from where we clamp the uterine vessel. So for the sake now, because we want to clamp and ligate our infundibulopelvic ligament, so I have safely seen my ureter. So now, with my finger, because this would be your peritoneum, I'm going to make a defect through my peritoneum. Normally we would both be on our finger. I'm going to create this defect. Okay. Haney. So curved Haney-Valentine is used. Heavy crushing forceps. So I'm going to clamp. My next step, again, coming through my peritoneal surface, I'm going to clamp. My ureter still is distal to my clamps. Male scissors. I'm now going to cut my infundibulopelvic ligament. Again, my ureter is here. And we would not be using our scissors to show that, but for the sake of the simulation, I'm showing you that the ureter is here, distal to the infundibulopelvic ligament. So typically, we take a tie. So this is 0 Vicryl tie. And I'm going to tie off my ligament with my ovarian vessels. Go ahead and flash that for me. Notice that I'm tying down to the vessels as opposed to pulling up on the vessels because I don't want to avulse the vessels. Suture, suture. So typically in the operating room, we would never rely on one suture for our infundibulopelvic ligament, but for the sake of this simulation, we're going to rely on one. Okay, so I would have put a second tie around here, and sometimes people put a third suture ligature around this. You can take that off. Take a 0 Vicryl tie again, so I can tie off the other part of my pedicle. Around. And this is simplicity of getting into the retroperitoneal space. So again, the key points of this dissection, flash for me, is it's long. If you go in as distal to the round ligament as possible, you'll be closer to the lateral side wall that allows you to enter this, what we consider to be the paravesical space. We know that deeper down we can get into the pararectal spaces, but for the sake of this simulation, we're focusing on the paravesical space. Go ahead and take that off. So here is our infundibulopelvic ligament. Just to reiterate, we divided the round ligament lateral closer to the insertion of the inguinal canal. We were able to tent up on our posterior sheath of the broad ligament in order to open up lateral to the pelvic sidewall, spreading, whether it's with your fingers, a Kittner, or the back of your forceps using suction. We were able to identify our ureter, which is here. And there's our ureter, which again, remember that the ureter starts at the pelvic brim, crosses over the common iliac laterally, and then moves its way medially to dive into the posterior sheath of the broad ligament. And then it continues to dive where it's about 0.5 to 2.5 centimeter from the uterine vessels, and then continue medially to dive into the posterior aspect of the bladder. And this is important anatomical knowledge that is needed for the expert surgeon in complicated laparotomies.